Everybody, I'm Dr. Cohen. As you know, I trained at downstate in head and neck surgery, and then, are you downstate as well? Awesome, excellent. It's an interesting place to train. Everyone's like, yeah.
Not aesthetic.
It's not aesthetic, no. And then went to the Midwest where I did a reconstructive fellowship at University of Wisconsin in Madison.
Wisconsin and Madison.
Yeah, it's a great town, great program. Practiced in the Dakotas for a while, flying planes back and forth between Fargo and Sioux Falls to see patients. And then have been around and made it back to do aesthetics for a while with Lana at Lana Spa in Tribeca. And now I just joined a practice in New Jersey. But I'm still close and still happy to share with you all what I know about PRP and fillers and neuromuscular blockade, but we're going to do PRP today, or platelet-rich fibrin matrix, which is really a form of PRP that you can use, and we'll get into talking about both of those. So, okay, I'm going to see, you'll have to advance, actually. I moved my hand across something. Just use the, you could use a right arrow key, I think. This is a whole field of regenerative medicine, obviously. That's what we're doing. We're trying to get the body to stimulate itself to repair tissues. And that's what we're going to use PRP for. So I'm going to advance past this really quickly because you can advance again. Or maybe I should, I don't know, hit this or something like that and keep going. Or maybe I'll just bring that. So what is PRP? Platelet-rich plasma. I mean, you all are doctors, so we can advance, keep advancing. We know that it is our... advancing to the same thing. Obviously, the platelets start at the megakaryocytes and this differentiation of them, and they differentiate to form, if we remember, all these little vesicles in them, the alpha granules that have all these myriad of growth factors that do heal the body when they come to a clot or a cut, and that's what we're trying to concentrate, that regenerative ability of platelets. You can go again. In those platelets, beside thrombin and growth factors and the alpha granules, what are the tricks we can use to get them to release those things? What do they release? When do we want them released? We're going to go into all of that. You can go ahead. These alpha granules, they're released when the platelets are activated. And so we activate those platelets in several different ways. If we go back to the clotting cascade, but one of the big ways we activate them is with calcium. And I say that, and I'm going over this a little bit because that kind of defines the difference between PRP and PRFM a little bit, activated versus non-activated platelets. We can go ahead. So these alpha granules have transforming growth factors which control cell growth, fibroblast growth factors to recruit and differentiate fibroblasts, endothelial growth factors that stimulate angiogenesis, platelet-derived growth factors, and then CD34 positive cells are attracted cell adhesion factors that recruit other lymphocytes to the area to remodel tissue. That's what we want. That's what we're going for with PRP injections. When we inject PRP in the face, we want remodeling of scar tissue. If we inject it under scars, we want recruitment of macrophages. We want deposition of collagen. So PRP ultimately acts almost like a facial filler if you use it for that purpose, or if you use it for wound regenerative purposes. You can go forward. So platelet-rich plasma. What we do is we take blood, and we've all seen this tube that separates red blood cells before, and in this tube where it has been centrifuged, you have the plasma at the top, you have the buffy coat. The buffy coat contains white blood cells, but it also contains the platelets. And what we really want to do is get rid of everything south of the buffy coat, but also get rid of the majority of white blood cells. Now, I'll tell you it's a debate how many white blood cells you're supposed to have in this solution, because what does that do for the healing process? The answer is we don't completely know, but we want the majority of them gone, because whatever we do with PRP, we want it to be as precise, as reliable as possible from patient to patient. So we want to try to use the same method. We don't want to give one PRP solution to one patient for one injection and really have a completely different platelet concentration, a completely different white blood cell concentration with the next patient you do. So what I would suggest is if you use PRP and you start using a method that works for you, stick with that until you are convinced scientifically or otherwise by the literature that something is better. And that's so you can reliably look at your patients and say, yes, I've been using this method and it's been working in this way, and I know I'm using the same thing. Because what you'll find out is between different companies, and not even different companies, but different protocols for creating PRP, there can be huge variability in white blood cell count, platelets, the quality you get, what you're doing with it. So you want to kind of take out those variables as much as possible. Platelet-rich plasma can be available in a liquid or the gel. When you're talking about the gel, you're really talking about activated PRP, which then is sort of PRFM, but we'll sort of talk about that in a second. You can go on to the next slide. So mention PRP and what it is. It's just plasma or a solution with the platelets essentially resuspended. So you're resuspending a small amount of plasma with supra-normal concentrations of platelets. And I'll talk about the number you want in a second. But PRP is essentially that plasma. This is true, like sort of, you go back to the original papers of PRFM, they activate the platelets, they convert the fibrinogen to fibrin that's still in the plasma, and they actually form a gel or a fibrin meshwork. And so in this sense, PRFM is used as a sort of film or a mesh that can be implanted to repair, like the spinal column is what orthopedic surgeons use it for predominantly, or to actually lay in the meniscus of a repaired joint. So primarily for orthopedic reasons. Now what you'll find that companies will say, oh, we're providing PRFM because we're just activating the PRP right before you inject it, and it forms like a gel, and then you've got like 15 minutes to inject it before it's like totally clotted, and they'll sort of say that's PRFM. And it is. I mean, it's all activated, but really PRFM, if you go back in the literature, is kind of this more specific form where they've activated it, centrifuged it down into a film, so it's actually a fibrin matrix, and then they're implanting pieces of that matrix to repair that. So they're actually using it for surgical implantation. Anything that's injectable, it sort of is in this area of is it PRFM or just activated PRP? It's kind of a gray area, but just so you sort of know the differences in what people are talking about in the literature. If you go to the scientific literature, they don't even use the term PRP and PRFM. They use platelet, supratherapeutic platelet PRP, and they just have all these abbreviations for whether it's leukocyte-rich PRP, and so you'll see that in the literature. So they don't actually use those two things. But okay, next slide. I feel like I'm very close to this. PRFM versus PRP. The companies that say, oh, we're producing a kit and here's PRFM that you're making by activating it, what's the advantage of activating it beforehand? Well, they say if you're putting it in beforehand, the scaffolding traps all the growth factors and cytokines in that area, and therefore it should work better. So it's going to lead to more efficient cell migration because everything is sort of trapped in that. And as I said, it's primarily used in meniscus repair, rotator cuff repair, ligament repair, although there are companies that make kits that activate the PRP. Are we allowed to say the names of? Well, I have them in this, but you know, like Cellful is one, but there are other companies that make PRFM where you activate it with calcium, and then they say, you know, that's now PRFM, and the advantage of it is you're trapping everything in that area. Now, you could also make the jump and step that when you inject PRP under the skin, what happens as soon as it goes under the skin within like a few minutes? It becomes activated because of the extracellular matrix and calcium that's in the tissue. So it's kind of like we don't really know which actually works better. There are some studies that will point a little bit toward activated PRP may work a little bit better, but it's more that there are probably more studies with activated PRP being used. So I'll get into that literature in a second. Disadvantage of using PRF, if you activate the PRP with calcium or thrombin or whatever you decide to activate it with, the disadvantage of that is that you have a limited amount of time to inject it. So if you're using it for hair restoration, you really, every vial you pull up, you've got just about 10 minutes before your whole kit is solubilized. And we've had that happen several times. I've had that happen several times. I've used both and then been like, oh, I can't inject this anymore because it's all solidified. Okay, next. So what happens when it's injected under the skin? You all kind of know the clotting cascade, but the platelet clot forms a fibrin mesh. All those growth factors are released. The target cells that you want to come in, the mesenchymal cells, osteoblasts, fibroblasts come in, and then you start getting new collagen synthesis. You can remodel scar tissue if you inject it under a scar that you've subcised. You can go on to the next one. So really quickly, when would you not use this? These are kind of common sense things. You're not going to harvest somebody's blood to get their platelets if they're thrombocytopenic. You're not going to get a high enough concentration. Really, that's really the problem. I mean, taking a small amount of blood from somebody is not going to hurt them, but you're obviously not going to stick a needle if they've got septicemia or some bacterial infection or a local infection. Relative, if they're on anticoagulation, again, some of this stuff is, like it says if they're on systemic corticosteroids or you've injected steroids, let's say you're using it for wound healing. Well, again, this is something that the evidence out there, there's good evidence that it works, but there aren't still a ton of double-blind, randomized, controlled trials. So in your practice, you want to really know that it's working and who it's working for, and you want to minimize the number of variables that you're using. So let's say you were injecting it in someone's joint for inflammation or rotator cuff or something of the sort, and not just for aesthetics. If you inject steroid at the same time, then you really have no idea, which is working. So you kind of want to try to minimize those variables.
Question, with the thrombocytopenia, so if someone has, low normal platelet count,
Mm-hmm.
is there something with the kits that will tell you we don't have enough platelets to make this?
You can get none of the kits have their own counter, but you can get one. And a colleague of mine who does hair restoration in Florida, they have one in their clinic, and they just do a platelet count on the.
Is it beneficial to have someone have a platelet level prior to signing them up for this?
We never do practically. We actually never do because we just make these because, we're kind of do it anyway. I mean, I guess if you really start tinkering with minutia of things and you were say, man, it works on these people, why didn't it work on these people? It could be that those people had a low platelet count. It actually, if you have a platelet counter, if you're using it, let's say you're doing a lot of hair restoration, you're using it, and you have a platelet counter, it makes more sense just to test the solution that you've drawn, because if you test the patient beforehand, you don't really need to do that. It's more important what you're injecting. And I'll get into the number that there's kind of evidence for of kind of what you want. But then you can also get into the notion that, well, maybe you could get by with less of a platelet count if you activate it beforehand. That's what the companies that push activating it beforehand say. They say, oh, you don't need as much of a platelet count because you're going to activate it with calcium and then it's just keeping it there. Well, then really what you're doing is you're injecting just plasma that's been activated, and maybe there is benefit to that. Back into the body.
I have another question.
Yeah.
Or people who have comorbid states like diabetes or that, if you've already injected it and it's activated, maybe you're better than if you depend on their body to activate it. Does that make sense?
Yeah, so the extracellular matrix and, when you inject it and you're separating tissue planes, you're lysing cells that are going to essentially activate the clotting cascade, and the calcium in the extracellular tissue is going to activate it. The real answer to your question is we don't know. I mean, we don't know when you start getting into little variables like that. I don't think diabetes would necessarily make any difference in terms of activating it because it's just extracellular matrix thrombin and calcium that's activating, platelets. So I don't think that hyperglycemia is going to affect that. It's not necessarily an issue with that, but it's the real answer is we don't know, which is essentially definitively better. But I'll get into showing you some of the studies and what they say. Okay, we can go to the next one. Okay, I pulled up some examples of, I want to make this talk as sort of evidence-based as possible because in aesthetics we do a lot of stuff that is not the stuff that we normally rely on when we talk about we're anesthesia or our doctors, where we're like, this has to have as much evidence-based, randomized, placebo-controlled trials as possible. A lot of stuff in aesthetics is anecdotal. A lot of it is. But PRP, even when I was doing oncologic reconstruction and working with orthopedic surgeons for other reasons, there are a number of trials that are out there, various institutions, and at Sanford in the Midwest where I was in South Dakota, there were several big PRP trials that are legitimate, good multi-institutional trials, and some of these are case series of people, of things that started those trials, and I'm going to go over some of the trials that are actually still in process. But essentially, the literature, if you like Google PubMed PRP, it goes from 15 years ago, just a couple of studies, to literally now 1,000 per year. So we're going to get really good answers to some of these questions over the next few years. But tendon and ligament repair is one of the big things you see it being used for. You'll see this on almost weekly on ESPN now. If you turn it on, you'll hear that somebody is just got their knee injured, somebody just got something injured, and they'll say, went for a PRP shot injection, and they're getting it injected into their joint, because there is some literature out there that these tissues do heal better when you have platelets that are activated, injected into a wound. The common things you see it being used for: Achilles, patellar, tennis elbow, rotator cuff injuries, when the ligament is overstretched or sprained. I can tell you that if you turn on the news, orthopedic surgeons after ACL repairs are injecting it around that repair to try to get faster wound healing. You can go on to the next one.
How many treatments do they need?
This is not, as I said, it's not a double-blind, there's no trials that say that. So you will find people, we'll talk a little bit more about that with hair, because there's a little more evidence with hair about how many you need. But when you talk about repairing an injury that something is possibly going to get better over time anyway, you will have people inject it once. You will have someone say, this injury is still nagging, I'll inject it every 2 months for 4 times. There's a wide variability. So that's why I said if you start injecting it for wound healing, like you're in anesthesia and you're using it for tennis elbow or for, or some wound, do it. Try to, whatever you start doing it at, try to maintain that protocol for a while so you get the sense of how much it's helping with you until you see something in the literature, the orthopedic literature, the pain control literature, the anesthesia literature, whatever, that's giving you something better. Okay, or until some of these trials come in. Because again, the answer to your question is, we don't exactly know. We know that it helps. Like if you look at, and I'll show you some of that. We can go on to the next one. This is a big trial that's out for Achilles tendon healing right now. It's a multi-center trial, and some of the initial return on Achilles, when they're actually looking at MRIs, but they've actually done biopsies of the Achilles, show improvement in remodeling, and people get back to normal Achilles function and elasticity quicker with PRP over saline injection. So
How much do you inject?
this is going to be just a couple cc's. I mean, you're really just injecting it around the tendon. I do have a little thing that sort of gives you a number depending on where what joint you're injecting into, approximately what people are injecting. But if you look up the literature for injecting a joint for steroid relief and you do pain as well, you're injecting essentially the same amount. You're just sort of...
I do this in my real job. Sorry, I mean to
No,
interrupt.
yeah, go ahead.
Which is like, it's not really insurance covered, but they're getting a little... So for this, it's really important never to inject in the tendon itself, because you can cause worsening.
Yeah, that's absolutely true. You don't want to cause tendon rupture, and you don't want to cause pain.
People are throwing steroids at everything, and now everyone is getting like worse diabetes, metabolic syndrome, so this is nice. And the worst thing that'll happen is that it doesn't work that well. So
Yeah.
I do it a lot in the epidural space.
We did it on a guy who had tennis elbow. My husband's an ultrasound guy.
Yeah.
So we did it ultrasound guided, and he needed it 3 times.
PRP.
PRP.
Yeah.
And he was a hand surgeon, so we really,
I mean, the nice thing about it, like she said, is there's not the downside of injecting. Yeah, steroids help, but there's also risk of a lot of other things with steroids.
And women, yeah.
Yeah, I mean, and not just that, like locally, there's a risk with steroid too. I mean, you can certainly cause, you can cause tendon rupture with steroid injection. And systemic steroids, as you said,
Yeah.
diabetes, femoral necrosis, which, I mean, those things are horrible. I've seen jaw necrosis with people on steroids before. So she's looking at me because she's like, whenever I get sick, my doctor gives me a shot of steroids and I feel much better.
Yeah,
But
yeah.
there are,
Bad.
but there are risks. There are risks to that. That's kind of the,
People are steroid happy.
well, yeah, they're steroid happy.
Especially dermatologists.
Yeah. Yep. No, that is true. Well, yeah, head and neck surgeons, I mean, we give them for a lot of things, but we try to make it as defined as possible. But yes, so there is evidence that it helps for tendon regeneration. Can you advance to the next one? Just the right arrow or the right arrow? Arrow. Arrow.
I got it.
Yeah. Osteoarthritis. It has been shown to actually help and start to regenerate cartilage. And those studies have been shown pathologically, actually, in a couple animal studies as well. They've seen it on imaging studies. And these joint studies have shown some, there are more studies that show improvement with PRFM than PRP. And that's just because the orthopedic surgeons have been using PRFM more. And it's primarily because PRP was really first utilized, and PRFM was first utilized for spine surgeons to repair meniscus and after spinal fusions. And so they kind of jumped on that and they used it more for joints. And so they use PRFM more in their literature. These are joint volumes that you'll typically see, you know, Achilles and in the elbow and the AC joint. I mean, it's a very small cavity. You're only going to get a cc around that joint for improvement. So
And you don't need lighter with that.
I mean, you could put
Like a
lead on,
skin
you could put
wheel.
lead on the skin, but it's one injection point. So
No, but you don't put it in the.
no,
Like
No.
a little skin wheel, like
yeah,
to bring
right,
in skin wheel just for the point of entry.
yeah.
I usually do a little lighter, especially from the reunion. You know,
A little bit of what?
Lighter. I'll do a lighter separate. You're not going to mix it with the PRP, but you know, you want to make them as comfortable as possible.
We can go on to the next one. I mentioned this already. These were a couple that pulled up from 2010. Tiger Woods has made the news many times for getting PRP injections. When the Pittsburgh Steelers won the Super Bowl, they actually, one of the Steelers players like came on and was like, I think it was like the PRP. I mean, it was like kind of a boom for like PRP because he was like, I don't think I would have been able to play if it wasn't for that PRP shot I got. And he literally like said that in the interview. So then now that's why it's become extremely that's actually a reason why it's become extremely popular. But hearing that people like Tiger Woods are getting it, and literally, if you just watch ESPN or some sports show like that, I mean, I just heard them mention it the other night. I mean, it's so matter of fact now in the orthopedic world that if someone has a chronic injury, it's like, went to get PRP injected. So we can go to the next one. Another area that really took off that you see for regenerative medicine that there's good evidence for, and you can start to make the case, okay, why are we using it in aesthetics? Dental procedures, cavities after tooth extractions, using it for gum restoration. There's actually good evidence that it works better than a lot of other things. This is one of the trials. There's several trials that it works better than not using it to show that this was for receding gums, but people have used it for oroantral fistulas, for sinus lift repair, for cleft bone repair, mixing it with bone morphogenic protein as opposed to just using bone morphogenic protein alone. I haven't used it for this, but I probably would now. When I was doing jaw restoration and facial restoration a couple of years ago, we used BMP as well as a lot of other things to repair bone, and I just, at that point in time, I wasn't doing PRP, so I didn't ever think of using it. I would actually take those proteins and just mix it with patients' blood in the operating room. So it makes sense that probably PRP would work well. Continue forward. So of course, if it repairs bones, people are using it for spinal fusion. Fibrin is the big company that really started with PRFM. They're using it for, orthopedic surgeons have been using it for some time now in spinal fusions successfully. aiding in bone healing. You can go on to the next one. Okay, so again, look at the studies that are out there. I'm going to go through some of them, but the real crux of it is whatever you start doing, I would suggest try to, unless you have a really good reason to switch, if you find that it's working, stay with that so you can go back and sort of look at your cohort of patients and tinker with one thing at a time. If you do inject it in joints, make sure to get pre and post x-rays or MRIs so you can say, hey, it did help or it didn't help, so you know for yourself and you feel comfortable with it.
Is it covered by insurance?
No,
No.
no, it's not.
If you're using an intraop, like in spine guys, that's different.
Yes, if you use it intraoperatively, pretty much everything is
But even
covered.
these
But
joints, like the epidural steroid injection will be covered, but not here.
yeah, that's correct. Again, this is the question you asked. There are no specific guidelines for re-injection. So even for hair restoration, the trials that are out there show 3 injections provides benefit. And so that's what everyone generally does. They say you need at least 3. However, there's just not a trial saying that 6 would be better, although anecdotally people do see if you keep injecting it more times or if people don't have enough hair growth, they might still get improvement with later injections. It becomes a cost issue, of course, if someone's paying $700 to $1,200 per injection. But there are plenty of people that offer more than 3 injections for various reasons. So we can go on to the next one. So let's get into a little bit of what's out there for aesthetics, because that's why we're here. I just wanted to show you that there's this background of actual evidence for it repairing, remodeling collagen, joints, those sorts of things. So yes, so that's the evidence that we sort of needed to say, hey, can we use this like a filler to remodel the face and remodel collagen? Scafani, who's here in New York, published his data with 50 patients, treated probably things you heard yesterday, hopefully nasolabial folds, volume depleted mid-face, superficial rhytids, acne scars. He did a number of things. Because you're just injecting, whether you inject PRP or saline, it's going to act like a filler for a little bit until it goes away, of course. But you want to see lasting results beyond that. So his initial stuff, 5 to 7 days after treatment, 90%, notice improvement. That's expected because if you just injected saline, you'd notice improvement in your face after that point. But 90% noticed continued improvement 2 to 4 weeks after treatment. And he has more data, you can go on to the next one, that actually showed months later, here nasolabial and fold injections with just PRP, and that's at 3 and 6 months. So we actually have patients that we've done at our prior courses. Lana's mother, who's had PRP done, looks great. Looks great, actually months later. So does it work? Yeah, it does. Does it last as long as fillers? We don't know. But it works well enough that you'd almost say, well, it's a completely non-reactive, patient's never going to have allergic reaction to it. They're essentially never going to have a problem with it unless they have a problem with the injection. It's certainly worth offering that option. And if there's the real advantage of it for aesthetics is this. Any patient that comes in and says, what is this material though? What's it made of? I'm a little bit apprehensive about having some artificial, even though it's hyaluronic acid, they're cross-linked hyaluronic acid, so there's potential for immunological reaction to it. So if someone has any apprehension about that, then PRP is an excellent option for them. You just have to counsel them and say that this may not last as long. It may not provide the benefit. You may need multiple injections. But you can also market it as this is a more natural way to restore volume in your face. And I think that's the advantage of using it. Okay, and go on to the next one. Nasolabial folds, this is another woman that had it injected. Not as dramatic of, oh, they're gone. This is one injection of PRP, though. You can kind of get the summation that if someone was willing to pay that and they were apprehensive about using fillers, I mean, you could get rid of these nasolabial folds immediately if you injected fillers and they'd be gone, for 6 months, a year, et cetera. PRFM, you're going to get a blunting of that, or PRP, but you could say, hey, we could do it 3 times and you'd probably get good collagen formation. Of course, with traditional fillers, cross-link, hyaluronic acid fillers, or whatever fillers you use, the purpose of those actually, to an extent, is to cause remodeling of local tissues and inflammation. So you actually need less of them to, in a sense, over time. But next one.
What is that timeline there?
This was 3 months later, I believe. Yeah, from the top to the bottom.
And PRP and not PRPFM?
This is PRP.
Do you think FM would have done? I don't know.
I don't know.
That's why.
I don't know. I don't know the answer to that. Continue on. This is all from Sclafani's paper, actually, still. These are acne scars that had subcision, so that's a good reason why they might be less as well, although they tend to come back if you just subside them to where they are and you don't put any filler or anything underneath them. But there's certainly a lightening of them, less of a depression with them. Go on to the next one.
What does subcision mean?
Subcision is where you release the scar from underneath. So you can, classic way to do it is you can make a needle stick, and underneath the scar you can essentially move the needle back and forth, and you can subcise it, like cut off its root essentially, so you can put something underneath it.
Can you do that with a cannula?
You probably cannot do it with a cannula, no. I was trying to think if you could manage to do that, but probably not. Yeah. This is essentially, if you're doing total volume restoration on the face, I mean, I know you guys yesterday in the lectures, you looked at fillers and they probably said, okay, you can inject here to do cheeks and do this specific volume restoration. You can inject, they say, glabellar lines or nasolabial folds or et cetera, and restore these certain volume areas in little places. But you can actually, with fillers, if someone's willing to pay, you can do what's called a liquid facelift and really restore the volume to the entire face. Like if someone wants a really youthful appearance to their face and they have the ability to expend that much to do it, you can provide volume restoration to the whole face. Well, PRP, because you have this larger volume of material, you can actually think about doing that more often. You don't just have to inject in the cheeks. You can really think about tear troughs, cheeks, forehead, and then you sort of get a very youthful appearance to the face, and you're sort of re-stimulating collagen growth in the face. You're still going to do traditional areas where, let's say you want to get rid of nasolabial folds, you're going to put more in the cheeks to sort of elevate the face. But essentially what this is saying is you can use PRP to inject in multiple areas of the face for volume restoration, and it doesn't have to be really as specific as the fillers you put in that are going to kind of stay in one area. You're doing an overall volume restoration. You can use it the same way as fillers, but you can also inject a little more liberally, and it's going to go down, much quicker. You can go to the next one.
I have another question. Can you grow, I'm sorry, eyebrows?
Yeah, no.
With
Theoretically, you should be able to. I haven't heard of anybody, someone asked that question before. Like theoretically, if someone has thinning eyebrows, I would think that you would be able to. I haven't seen anyone specifically do that.
Anywhere that hair.
Yeah, anywhere that hair roots are.
It will, because some people have this scar tissue in their eyebrows, and I've seen that in like normal aesthetic
Yeah.
practices. Like they would have like like say they have a scar. Have you seen that? Like running through the eyebrow. They would use PRP.
So I did a patient with PRP.
Mhm.
She called me up like 2 months later and said, is it possible that the PRP that you put into me has grown my eyebrows? And I'm like, well,
Unless
I do
you-
it on head, but you know what? I didn't.
Unless you put it into her eyebrows, I would have doubts. But I mean, anything's possible that it could cause like
Or maybe
local
because
inflammatory
everything else
response.
was so glowy that it was more defined instead of
Yeah.
sinking in.
Well, so I have people that I've done, hair reduction on.
Mhm.
Well, is that going to grow my, is it going to grow
If
my
you've
hair
done
back?
hair reduction and eliminated the hair follicles, I mean PRP is like fertilizer for the seeds or roots that are already there. So one thing that I will say that you typically don't see it working on, we're going to get into hair in a few moments, but you're not going to do it on someone who's a Norwood 6, completely bald, because there are no seeds there. There's no hair roots. However, I've had colleagues of mine of people that have shown they just had little patches of hair on either side. They didn't want to get hair transplant surgery. and he injected PRP in the scalp, and they did get some hair regrowth. They had faint kind of lanugo over their heads, so it was causing, but then they actually got maturation of those into traditional, out of the anagen phase of hair and into growth phase. So this is how this sort of actually became super popular, is because Kardashian posted a picture of her being microneedling, getting microneedled, and getting a vampire facial, which traditionally is actually, I mean, now a lot of people are just doing PRP on the face as they're doing microneedling. Although logically, you would think that it would have a little more efficacy if you injected. So my personal view on it would be to actually do microneedle and then inject PRP at a separate session, if you're really trying to get volume restoration. But if you're just trying to get rid of fine lines and wrinkles and tiny little acne scars, then yeah, absolutely. Then PRP with microneedling and doing sort of the traditional vampire facial thing is fine. I'm not saying this, by the way, because this is not up here, because this guy is like, that's patented, that term. You can't advertise, unless you pay him like $4,800 a year or something, you can't use the term vampire facial in your practice. You can go on to the next one.
Why, do you think you can inject at the same time you do the microneedling or no?
Yeah, you can.
You can?
Yeah.
Okay.
Yeah.
It makes sense. I don't know.
Yeah, it's fine.
Topical.
Yeah, I mean, if you microneedle though, you're causing, I mean, the face is going to be uncomfortable, and I mean, I would inject first and then microneedle after. Don't do it the other way around.
But is it better to wait?
I don't think it would matter at all.
Okay.
No. Evidence for PRP with microneedling. There's a randomized trial, 90 patients with atrophic scars, 28 patients treated with microneedling, 34 patients treated with intradermal injection of platelet-rich plasma, and then 28 patients treated with alternate sessions of microneedling and PRP, and there was more objective improvement with the PRP with microneedling. You can go on to the next one. You're going to see a lot more of these trials coming out. So for your practice, do you get as much improvement if someone's got a face like this as you would with laser? No. But if there is, for whatever reason, apprehension to use that, if it's a cost issue, there is improvement over just microneedling alone using PRP for atrophic scarring.
If you're gonna inject it topically, like if you're gonna inject it and then microneedle, you have to use a different size needle, like as far as the microneedling goes, like a different size. And if you're going to put it on topically.
Well, it depends on what you're talking about for what you're injecting. If you're like injecting into I wouldn't inject it like you're injecting into the dermis. If you're injecting PRP at the same session as microneedling, you've got to think of you're using the PRP like a filler. Okay, so I wouldn't inject, one of these trials they injected into the dermis and then microneedled on a separate session. You wouldn't want to inject it into the dermis and then microneedle that same session, because then you're actually just kind of taking it out. But if you're using it like a filler, essentially what your question is could you inject fillers almost the same day you do microneedling? Yeah, I mean, you can. You can, although I would, if it's traditional fillers, I'd separate them out, simply because you don't want to cause a lot of inflammation in the area. But with PRP, it's your own platelets, your own plasma, you're not producing any type of inflammatory reaction really, or very minimal. I think it's fine to do the same day. Traditional fillers, I'd wait a little bit, because you're not going to want to cause a lot of local inflammation in the same area. And if you're microneedling and you put fillers in, you don't want to move that filler around by pushing the microneedling pin around on the face.
So microneedle first and then PRP. Is that what you said?
Well, just I would, if you're going to do PRP, you could essentially do them the same day. But no, I would. It's actually easier. Practicality. I've only really. No, do PRP. If you're gonna inject PRP, you could do it the same day. It's fine. But
What would you do first?
the
microneedling or
PRP. The PRP. But I'd say just separate them out. It's just practically easier, actually. You can go on to the next one. There are, here are all these trials. There are a number out there for PRP with acne scars. 2016, 2011, 2014, microneedling plus PRP had more improvement over PRP, or here's microneedling with distilled water, microneedling with vitamin C, PRP versus that, and the PRP patients all had improvement over those controls. You can go on to the next one. So PRP with microneedling, I mentioned that because it may augment, there's evidence that it seems to augment the effects of just microneedling alone. There's evidence for improvement with acne scarring versus either modality alone. So if you do PRP with microneedling, it seems to work better than just PRP alone or just microneedling alone. There's some evidence for that. Now, the magnitude of that is not extremely high, but it's there, and is it going to work better than laser resurfacing? My opinion is probably not, but it's not as, price-wise, it might be, it's definitely going to end up being cheaper for a patient. You can go to the next one. This was PRP with microneedling for this patient. I think this is one of Hardig's patients.
What is the timeline there?
Yeah.
What was the timeline there?
I'd have to ask him. This was his patient, so I'd have to ask him what the timeline was for this. You mean like before, and how long? Like, I don't know. I think a couple of months. And
And is that microneedling RF?
No, it's just microneedling with PRP dripped on. Okay, you can go to the next one.
Wow.
Oh, wow.
So not completely to the point whether you get with laser resurfacing, but it's definitely a significant improvement. You can go to the next one.
There's always room for recovery time.
And then one of the things that you actually have seen a lot of use for now is, of course, women having low V-cut shirts and sun exposure. The further south you go is the changes and the lack of volume and the discoloration and all that things that you get at the Decollete area, and PRP is being used for that, and it produces actually a nice sort of volume restoration in the lower neck. I can tell you some of the trials as a cancer reconstructive surgeon, some of the trials that we used it for are post-radiated necks, and there's a lot of those trials that are underway right now. But so the jump is there that you could use it on people that haven't been radiated by radiation therapy, but radiated by the sun over a long time, or just have volume loss in their lower cervical region or upper chest. You can go on to the next one. And so, again, this is just say, what's the theory behind this? Of course, it's exactly what I said. It's just causing new collagen formation and creating new deposition of collagen and remodeling of scars. Continue to the next one. Just to go over the advantages. And why do I say this again? Because this is what you're going to say to your patients. Like, this is, why would I use this? Hey, do you do PRP? I heard this. What are the advantages of it? Or how to market it to somebody who immediately has some apprehension about having something that's autologous injected into their body. It's natural, non-toxic, no allergic reactions. The other dermal, it's going to have a little bit more of a limited lifespan, but it's also going to have an extremely short recovery time. As you know, when you inject fillers, you have a lot of swelling the next day. You get less of that, and it seems to be it's less irritating, less painful, and no chance of immunological reaction. Convenience also is that you don't ever have to wait for supplies to come in. If you don't have them in your office and you have a PRP centrifuge there, you just have to draw their blood. It literally takes 20 minutes to do. So you can go on to the next one. So I did break on this. There's kind of a hilarious thing. If you Google, I just wanted some images, so I just typed in on Google image hair restoration. And I was like, oh, this is ridiculous. Obviously, Don King and Billy Ray and whoever that guy is. And I was like, oh, this girl. And I actually happened to click on the picture. And she's a famous model that has congenital alopecia. And she got a number of treatments, including that are not surgical, but a number of different ones, minoxidil. She got PRP. But she apparently had a phenomenal result and complete restoration of
That-
yeah, that's actually her, and she posted this like years later because she was like, clearly it worked for her, and I just thought it was ironic because she actually talks about it in that like Esquire magazine or something like that. She talks about getting PRP as well as a number of other things and having great results with it. But we can go on to the next one. So what are you trying to get with PRP for hair regrowth is that you want the hair goes through this long cycle of growth, mainly growth in this anagen phase, and then it starts to die, and then the root slowly like rebuds again and can regrow. And a lot of people that get hair loss, the root is still there. It's just prolonged in sort of this anagen phase for a lot of these people. And so these are the people that you want to try to capture where you were, a telogen or catagen phase, and you want to try to return to this growth phase. And that's what PRP is probably doing. Okay, now whether it's having direct effects on the follicle itself for growth, whether it's causing angioneogenesis, which is actually how it's now thought that probably minoxidil works, although there's a lot of debate about how it actually works. We don't know exactly how. Like if you do cell studies on minoxidil, there's some that show new vascular regrowth. There's some that show a decrease in DHT receptors, and so maybe that's causing it, but no one really knows. But so the angiogenesis is maybe thought to how this works, but we can go on to the next one. The treatments that are out there, okay? Oral pills, finasteride, topical minoxidil is apparently a vasodilator and possibly causes angioneogenesis. Then there is the phototherapies, low-level laser light therapies that you'll see in Sky Mall magazine and everything. Do they work? Yes. But do they work? That's where I always see them whenever I'm flying and I turn over. It's like there's always one, like what are the other companies, like Schlemmer or whatever. Then there's sort of the nutraceuticals, biotin, marine protein, topicals. Those topicals tend to just thicken hair, so they give you perception that the hair is regrowing. They keep hair from being brittle and fracturing, so it does thicken hair, and they do work together with this. And then there's sort of cell therapy that's actually causing the hair to regrow. The real thing is when you have a patient and you're considering using PRP for it, you don't have to be stuck to say, I'm just going to use PRP. You might as well give your patient every option. If they're still using minoxidil and they're okay using it, continue using it. And you'll sort of see that in what I talk about in a few minutes, that there are studies that show that concomitantly they work better. So go on to the next one, please. Here's the Norwood scale for baldness that I kind of referred to. But these Norwood 6s and 7s, it doesn't make as much sense to do it for those patients, albeit I've had a colleague of mine, Dr. Mascaro, down in Miami. I said that, and he was like, check out this guy. And he sent me a guy that was Norwood 7 who didn't want hair transplant surgery or didn't want scalp reduction surgery, which is one of the things that we'll do for hair restoration. And he did it on a guy like this. And the guy had not extremely thick hair, but he had hair regrowth over his whole scalp that he did PRP on.
How old is he?
In his 40s or 50s, I think. Yeah, I'm just going by his face that I saw, but probably in his 40s or 50s. You can go on to the next one. So here are the big studies that actually showed that it worked. Okay, here's 20 patients, 18 males, 2 females. Hair loss was reduced at 3 months. The hair growth on a quantitative scale, looking at specific areas of the scalp, actually reached normal levels. And at 6 months and a year, it was still significantly increased. These patients in this study got 3 injections. We can go on to the next one. No adverse effects on any of these people. We can go on to the next slide. Patients, here's one patients were followed for 2 years. This used the Cellfill, which is just an activated PRP. That's that company. 3 treatments were administered at 30-day intervals on half the scalp, and it increased hair growth in an area by essentially about 40%, 30 or 40% in the quantitative area that they measured. No adverse effects noted, and there were, of the 23 patients enrolled, you can see there were 4 patients that still had progressive hair loss at a year. So does it work for everybody? No, but neither does minoxidil, neither does Propecia work for everybody. And again, you can use them with each other, but this works significantly enough that is absolutely something to offer your patients. And then it starts to, when you use it for hair and you see the hair regrowth with it, then you start to get confident using it because you start to say, well, it's causing hair regrowth. It makes sense now that I might use it for joint reconstruction or for facial filler to cause collagen synthesis, because it kind of makes sense that it is working. It's not just a placebo. Okay, we can go into the next one. Same thing, hair regrowth. Everything that everyone else is using. One, it's not a surgery. It's not like neograft replacement. It's not taking Propecia that can cause, in men, as you know, impotence. It's not putting a topical on the head if they don't want to use that. It is something that, while it's a little uncomfortable to do it, it doesn't have any side effects to inject PRP into the scalp other than your scalp is a little tender for, half a day, essentially, depending on what you do. Quick, outpatient, they can come, you schedule an appointment with them, they can be in and out of your clinic in 45 minutes if you have everything set up right, or less than that, really. Go on to the next one. So these are pictures from, this is a plastic surgeon. You will see people, people will mix it now and they'll say, I mixed it with A-cell, or I mixed it with extracellular matrix harvested, stem cells harvested from cord blood, or whatever, all these different things. The reality is that when I talk to people and they're really doing a lot of PRP, they don't see a benefit from mixing it with this stuff. It's a cost more to the patient, but again, you can try it. You can try it, but they don't really see that add stuff. The only people that I've heard that have ever had complications with PRP injected in the scalp are when they've been mixed with other extracellular growth matrices, and that's probably because you're just mixing it with a foreign body, and those complications have been scalp infections. I've never seen or heard of anybody getting a scalp infection with just injecting PRP, though. So, just as an aside. If the literature starts coming out there, or you speak to a colleague that's doing PRP with A-cell or something of the sort, and you trust them and they say, no, it's absolutely better results, then you're more than welcome to do that. I haven't found that between me and my colleagues of people getting better results.
And A-cell is pig's bladder, right?
It is acellular dermis. I think it's cadaveric dermis.
Oh.
Yeah. Yeah. It's been. I thought it was. I thought it was cadaveric. I thought it was cadaveric. That it was just. Yeah, look it up. Look it up. I'm trying to remember it myself.
But that makes sense that you would get more.
Tell us as we go. I mentioned you can use it with other topicals. Here's. There are people that are microneedling PRP into the scalp, just like a vampire facial. And yes, it does seem to work, but microneedling the scalp, interestingly enough, causes hair regrowth too.
Just in and of itself?
In and of itself,
Yeah.
Microneedling the scalp causes hair regrowth. So it's obvious, just the local inflammatory factor. Now, it doesn't cause it. It actually doesn't seem, when I look at those studies, it does not seem to cause it on the level of injecting PRP. But here's someone that did minoxidil alone or minoxidil plus microneedling with PRP, and there was much greater improvement with the PRP. Obviously, if patients on minoxidil and they are willing to continue to do it, don't tell them, you have to stop. You can continue to use that. Continue on to the next one. There's definite evidence for growth, and you start to really see it in most of the studies at about 3 months. I injected PRP into my scalp once. I would say at 1 month I started noticing an improvement, and it's still, I need to do it more, but it's significantly improved over pictures that I go back and look at from 2 years ago. Very significantly improved after injecting it one time and starting at a month, but I would do say it maximized at about a few months out. So I think people probably do need 3. I know Heartache offers sometimes people 5 or 6 injections to get their hair where they want, and if you continuously see hair regrowth and they want to do it, then I think that's completely viable to do it. Again, it goes into your question, how many times? Well, the studies that are out there, generally people are just doing it 3 times, and that's just because that was the first study that someone did it 3 times, and so everyone has kind of been emulating that.
How far apart would you space that?
Oh, a month, 4 to 6 weeks. Yeah. Again, more because the platelets stay activated in that area for about that period of time. Anything else? You can go on to the next one. Again, complications just local from just needle injection. You know, bruising, scalp tenderness for half a day. Feel free again. They can continue finasteride. Some people say you should wait a couple weeks, but you know, I don't see any reason why after their scalp bruising or tenderness goes down after a couple days, they absolutely can resume normal topicals. The low-level laser light therapy, we do this course sometimes with Chris Asandra, who he pops up on the doctors occasionally. He was on there a couple weeks ago, but he has a number of med spas around the country, and he gave a great analogy, which I think is something that I'll repeat and is very marketable. He says that the PRP or PRFM is kind of like the fertilizer, and then you do a low-level laser light cap for your patients, which does help, and that's kind of like the sunlight for the plants that you're regrowing. And patients seem to really like that idea and get it. If you look at low-level laser light therapy, it does work. It does not work to the extent that that's advertised, but there are, again, a subset of people that it works really well for, so you might as well combine those two. There are a number of companies that make those caps. If you go and start looking for the low-level laser light therapy caps, they range anywhere from a couple $100s to several $1,000s. There's no need to tell your patients to get like the several $1,000 one. They can get the ones that are in the range of like $500, $600. They all use the same technology. It's just the company, is marketing it that way.
The patient uses it at home?
Patient sits with it at home. It's like 20 minutes. It's this cap that produces the low-level laser light therapy. They just sit around with it at home for 20 minutes several times a week while they're watching TV. You do want to question your patients on risk factors for possible endocrinological, thank you, causes for hair loss. Hypothyroidism is obviously a big one. So if they have, I don't always send my patients for labs. Some people do, but if they have concomitant risk factors and you sort of go through those questions and it sounds like they do, then you may want to send them for labs, or if it sounds like they have other reasons why they might have hair loss, you could always send them to endocrinology colleagues just to make sure there isn't another reason for their hair loss.
Is there a set of labs that you do?
Thyroid is just the biggest, but then if it sounds like they have, beside thyroid, and some people will just send everyone for a TSH. If it sounds like they don't, if it's not thyroid, but it could be some other endocrinological issue, then I would just go ahead and send them to endocrine.
But if they're treated thyroid, they're okay.
Yeah. I mean, at that point, if they are treated thyroid and their hair growth hasn't come back yet, then PRP is absolutely an option for them. I mean, the hair, then it's reasonable to try. Next one.
What about cancer patients who lose their hair?
Yeah, that is a really good question, and I have not used it for them.
We'd appreciate that.
Yeah, that is a good study. I will tell you that the PRP trials that, a lot of the hair loss that you get during chemotherapy does come back, but obviously the hair is thinner at that point. And so will PRP work for that? I think that's an excellent study to do. There was a trial at the institution I was at using PRP just after and during the completion of radiotherapy on the neck to reduce the woody neck. I don't know if you guys have ever seen post-radiated head and neck cancer patients, but their neck turns into a log, and so there's a lot of studies out there to try to eliminate that. And so PRP seems to help a little bit, but it hasn't reached the evidence that we're using it for that all the time. There's also the risk that you don't want to decrease the efficacy of whatever cancer treatment you get, so or like cause cancer growth. Most of those things have never really panned out, though.
Kind of like seed the cancer type
Yeah,
thing, right?
not seed it, but you're putting essentially growth factors in. Are you going to cause cancer to grow?
Chemo's doing the, that makes
Right, but but chemo and radiation, of course, are doing something different. They're actually causing DNA damage. So I mean, there's a big debate. There's always the debate of like, is giving hormonal therapy or other growth factors, if someone has a history of cancer, does that actually cause, say, breast cancer to grow? And like the studies have not panned out that that's true. What it's shown is that cancer that's there will grow more rapidly, but it was already there. Like you're not going to create a new, yeah, you're not going to create more. These are some more pictures that I think are good from a colleague that show the kind of results that you can get. People with sort of subtly thinning hair, where you get PRP and you get, I mean, these are your clientele that you really want to capture, where you sort of see up, you've got thinning hair and they're concerned about it. And man, a lot of these people, you get really good results with this. You go on to the next slide. Again, same thing.
That's after 3
Yeah.
treatments?
Yes. Yep.
How many months is that?
They're separated by a month. This is one of Hardig's patients.
So,
You can continue out.
1 month.
These are
just
3
3
injections.
treatments. 3 injections.
3 injections. The other question you're going to ask is, the other question you'd need to say is, how long does this last? And the studies have shown that it lasts up to 2 years. It probably lasts longer for some people. But I can tell you that it's absolutely worth, if someone were to say, hey, once every 2 years, you have to come in for 3 appointments to get your scalp injected and you'd have much thicker hair, I can tell you that I personally would be fine with that. So I think most people would be. You can go on to the next one.
Is one area of the head more responsive than another, like this?
I think the areas that are most responsive are, if you go back a slide,
More of a,
are just where you see hair. If an area is completely bald, you typically don't get as good of a response. Now, that being said, early on I showed you the picture of a guy who had that patch alopecia, and he had complete hair growth in that. Obviously, there were still follicles present, and they were just not in an anagen phase of growth, and so it stimulated that. So the answer is, no, we don't know that, but if someone's completely bald, anecdotally, they don't get as good of response. Again, I've had my colleague, Dr. Mascaro, send up, he totally agrees with what I'm saying on that, but he said, yeah, this guy really didn't want to get, he doesn't do neograft, he does individual follicle transplantation, but he was like, the guy didn't want transplantation surgery, he was really against any type of surgery, and he just did PRP over his whole scalp and got hair restoration over his entire scalp, and the guy was like a Norwood 6. So it does work on some people. We just don't know who those people are going to be.
Do you have a year cutoff? Like if you've been bald for 10 years, you're not going to respond as well as...
Well, that goes into that. Yeah, I mean, the people in the studies that they're recruiting are people that typically have not been bald for like 10 years. But if you have thinning hair, it seems to work better in those people. I would say a cutoff for nobody if they want something done. I mean, that's what I'm sort of saying. If they want something done and they don't want to go through, if they're Norwood 6 or 7 and they don't want to go through hair transplant surgery, then there's really a cutoff for no one. There are no side effects to this, really, very minimal. And you've got to tell them, hey, you could be one of the 20, 30% of people that gets a full head of hair from having this done. I don't know that, but you could be.
So would you wait 3 months if they have no growth after 3?
If you do,
every month for 3 months, then you're not.
I'm not going to do any more. No, I'd want to see growth. Yeah, I mean, you'd really want to see growth start to see growth at the 3rd month from the first 2 injections.
Okay.
If they have no growth by the 3rd month after 2 injections, then I'd tell them, look, most of the studies use 3. I'm certainly willing to do 3, but I think it's less likely now that you're going to get growth. This is a good way to really block their scalp. We do both. We'll put a lidocaine cream in their scalp and let it sit for about 20 minutes, and it numbs the scalp It numbs the scalp very well, but it also takes just a couple of minutes to just get the supratrochlear and supraorbital nerves as they come out there, and also the occipital nerve in the back.
Yeah.
And so I'll show you. It's very simple. Again, inject. Don't just go in and inject one spot. Inject and infiltrate a horizontal area so you're sure to get the nerve. Yeah, I'll show you. I'll show you too. It's pretty simple. Well, we can. It's not a difficult thing to do.
People will say, sorry, like
Yeah.
ultrasound is, it's all a gimmick. You can't really ultrasound your scalp head, and there's like the vessel is so difficult. You just go by feel on the tuberosity.
Yeah, yeah. You're just doing an area.
Like there's a divot, yeah.
Yeah, I mean, you can frequently feel the pulse of the supratrochlear and supraorbital artery, and the nerve is going to be right there. But you don't need to, because if you go, so here, if you go 1 centimeter lateral to the mid portion at the rhinion here at the top of the nose, you're going to start to get into these nerves, and then just inject this area right here. Okay, and in the back here, you put your finger on the mastoid, and then put your finger on the occipital protuberance in the back of their scalp, and then just, this divides it easily, just put another finger right in the middle between those two, and that area, if you inject horizontally, you'll get it.
What about the temporal part? Do you inject?
Yeah, you could inject great auricular. I mean, I use cream a lot too, so it tends to be pretty numb. I mean, you could inject greater. I usually don't, though. Just because by the time you get over there, the needle's really small and you're injecting pretty quickly, and yeah, it sometimes burns a little bit, but it's pretty tolerable.
So this is going to just, because some
If
of them
you-
have it on the temporal.
Yes, yeah,
you know?
yeah. And so you could inject over there, but yeah, this will get predominantly this whole area right in the middle. Yeah. You can go on to the next slide. Keep going.
Let me tell you that Emma,
Keep going. Just pop up these.
Emma? Yeah.
So just to review. Oh, yeah, go ahead.
She was saying that Emma's good, but what is your, I don't feel like there's enough penetration in the scalp, right, Emma?
What do
I
you use
use,
topically?
Oh no, there is.
There is.
Oh yeah.
So you do feel like it's good.
Oh yeah. I mean, I've had it. That's for when I had it done. I didn't have any injections for block. I just had
Okay, so
BLT
I
cream.
use BLT.
Yeah, BLT.
Yeah.
Yeah, BLT is better.
BLT is
here's a
more
model
than
patient.
Emma.
Yeah.
Okay, more than Emma.
I just had BLT and it worked.
Anticonvulsant.
It worked great. Remember, the
Yeah.
time you leave it on the skin, it's going to anesthetize it generally about double that period of time. So if you leave it on for 5 minutes, it tends to only actually anesthetize the skin for like 10 minutes.
Oh, I see.
So that's a good rule of thumb. And so if you leave it on somebody's skin for 30 minutes, it'll actually last for like about an hour.
Okay.
You don't need to leave it on that long, but you could leave it on for like 20 minutes, and that will be enough time. It'll be about enough time for you to get your injection done. PRP anesthetics, just to review, I mean, we've showed that people are using it with microneedling, and it has properties to seem to enhance the effects of microneedling, although that's going to pan out more in studies. Superficial scarring, it's certainly applicable to somebody that has mild acne scarring. If they have really heavy acne scarring, those will need to be subcised, and then you could inject PRP underneath it. Fine lines, volume rejuvenation, the paper from Scalfani, yes, it does work. The pictures you saw from Lana's mother and how much of a volume restoration, new collagen synthesis it provides. And then I just went over hair restoration. Yes, it does work. The thing to counsel patients is you find those patients that still have hair, they still have follicles present, and then you counsel them that this is a very natural, very non-obtrusive method that they can get hair regrowth where they can just take off a lunch break from work, go back to work, still be fine that same day, and they can get this done over a few month period and see hair regeneration.
I have another question.
What now? Is it Lana? Okay, just go click on the next slide. Just
Is
click.
it dark hair that grows, or if your hair is
Oh, I don't.
white,
It's not actually.
Oh, that's good, yeah.
I'm sorry.
dark hair that grows, or if your whole head is white, it's going to be white?
It's going to be whatever hair color.
oh, because you're stimulating.
Yeah, it's just stimulating growth of those follicles. I haven't seen it change hair color. If that's What?
If he has to.
Yeah, I just did it once though, but it made a big difference.
Made a big difference.
Yeah,
Where, can I ask, where did you get it?
my entire scalp was
Really?
But
thinning.
you didn't have anything, like.
Are you serious?
Oh, I mean, I did, but it was really thin. It was really thin.
Hairs.
Yeah, I mean, it was really thin over my whole scalp. So it was pretty good, and I'm busy. I just haven't bothered to.
But how long ago was that?
Months.
5 months ago? 6 months ago?
But
Yeah.
it just continued, like it's not.
Yeah, it
doesn't
stayed. It hasn't changed. So that's advantageous. Go on to the next one. I'll go into the processing of PRP, and then I'll have her come and talk about the O-shot and other things that we can use it for. But so how to process it, again, it's very simple. You collect blood, different kits, it's going to be different amounts. The PRFM kits tend to be smaller amounts, but you're collecting the blood, centrifuging it, and again, you're extracting the platelet-rich plasma and putting it back in the patient. Go ahead forward to the next slide. There are two methodologies when you sort of look at the literature of companies that kits provide. They have single spin kits where you're just centrifuging the material. You remember the centrifuge, and you have the plasma and the buffy coat, and you just do that single spin, and you're just kind of extracting the platelets from that. But then they also have double spin ones where you extract the platelets and the plasma from the top, and you spin it again to create a pellet of platelets, and then you resuspend that pellet into some other solution or the patient's own plasma. The ones that are dual spin, you sort of think about it, you're going to get a better harvesting of platelets from those, and you're going to be able to get higher platelet concentrations. Now this gets into the debate of which is better. Is it better to have higher platelet concentrations and then inject that into the patient, or is it fine to have lower platelet concentrations and just activate them? That's sort of still, we're going to see that as it pans out in the literature. The single spin, you withdraw the blood, you extract the top, and then you're just resuspending that and re-injecting it. Go ahead and go to the next one. The single spin devices, there are a number of them out there and a number of companies that offer them. Again, it's not a bad idea if you want to sort of have a platelet counter in your office so you know what you're injecting into the person, and I'll sort of show you why in a second. Continue on to the next slide. The double spin ones, as I mentioned, MSite is one, but there are a number of companies. You centrifuge a smaller amount for a bit of time. You remove the blood cell component, the red blood cell component, and you take out the serum component in the upper fraction, and then you do a second centrifugation. Go on to the next slide. The double spin devices, they all talk about the amount of immune cells you still have in them. There is some evidence that having a certain number, a small amount of lymphocytes actually helps with the remodeling and hair regeneration specifically. There are a number of devices that specifically market that and say we have a certain amount of white blood cells still present or a small amount. You can go on to the next slide. Next slide. I already mentioned the dual spin yields more platelets, greater reproducibility in how many platelets you're getting, because when you get a buffy coat and you're just trying to resuspend, you can imagine that you're missing a lot of those platelets when you do that. The single spin generally has to be utilized. When you do a single spin device, it has to be utilized quicker because you'll get activation of the platelets, and so you have to use that material faster. The dual spin devices, you have a little bit more leeway of when you inject it. May not really matter to you. I mean, you harvest the patient's blood. You only need to inject an entire scalp, you only need about 15 minutes, really. So you don't need that much time. But again, dual spin units, they're a greater amount of growth factors theoretically because you have more platelets.
If you could set your centrifuge to 3200 RPM, can you use a regular centrifuge or just have to be specific?
You can totally come up. You don't have to you buy a kit. You can just look at the literature, and you can use a red top tube and remove the red blood cells and just harvest the buffy coat and the plasma and mix it yourself and set your centrifuge appropriately. And that's, my friend in Florida does not use a kit because they don't like the overhead cost of that. They just like to order their own tube, so you can do that. But the kits are nice. And they take away, like, they also cause there's a cohesiveness again between patients that you're doing exactly the same thing. So, yeah. And when I talked to my colleague about that, exactly what I just said, well, he doesn't dual spin and et cetera, and he's like, well, he does hair transplant predominantly, actually surgical hair transplant, so he's kind of using it almost as an adjunct to say, like, well, if it works, it doesn't work, and if it doesn't work, then I can tell them that they need to get hair transplant anyway. So it just depends on what you do and what you're trying to get your patients to do. You can go on to the next one. It does, when you do get a centrifuge, though, it is important to make sure that there are regulations when you start doing things with this, bless you, when you start using the centrifuge and you're using it to harvest a patient's own blood, it is regulated that centrifuge has to be approved for use of human material for injection back into humans, and there are protocols for that. So the companies that sell those their centrifuges are licensed to be able to do that, and the kit comes with it, and they say, hey, we have this specific protocol that's FDA approved. For that, obviously, in an aesthetic practice, you can make your own protocol, but the centrifuge still has to be appropriately calibrated and regulated. You can go on to the next one. This goes into sort of the dose response I said. The only good study out there are a couple of them that show that for hair, not for hair regrowth, but for looking at tissue culture and animal studies, the best regenerative capacity seems to be when the platelets are at about 1.5 million per microliter. So you think it's like, if you have a patient that's thrombocytopenic and their platelets are 80,000, and your system says, oh, it'll concentrate platelets 5 times, you might not really get to, that's why you might not want to do it on somebody's thrombocytopenic, you just might not get it might not be as effective. Whereas if someone has platelets in the more normal range of like 200 to 400,000, then you do 5 times and you're really getting into the range that the tissue culture studies have shown that you get the best growth from that. You can go on to the next one. This is just to show, if you really go through the literature, that there are all these little sub things about PRP that scientists are starting to tinker with. How many leukocytes do you need, et cetera, et cetera. Some of the kits really market to that, and the one we'll be using today is like that. And they go through the literature and they say, hey, we're giving the exact amount of leukocytes that the literature are closer to the number of leukocytes that you want, closer to the platelet count that you want. And again, if you look at the literature, nothing says PRFM, but it's either all pure platelet-rich plasma or leukocyte, platelet-rich fibrin. Those are more sort of aesthetics things that people will say, those other terminologies. But you can go on to the next one. So all these kits have various ways of essentially doing this. You centrifuge the blood, you get the blood cells at the bottom, you get the plasma at the top, and you get your buffy coat in the center. Some of them have these kits where you just drain off the plasma at the top or drain away the blood cells at the bottom. But some of them have these little things like floating shelves that collect the buffy coat in sort of a floating shelf, and then you harvest it, actually put a needle in, and you harvest that buffy coat from that particular spot in the centrifuge. But again, there are all these companies that, go ahead and sort of look at them and look at the ones we have today and see which ones you think will work better for you. Go on to the next slide. Here's sort of insights, and what you'll be seeing today is what's nice about a lot of these kits is they have it's a closed environment. So if you use your own kit and you say, okay, I'm going to buy red top tubes and just do this myself, I mean, there's going to be pipetting and removing between tubes, and you've got to worry about that. The Insight kit is completely sterile. Nothing ever becomes non-enclosed. So you draw it from the patient into a tube, it goes into the centrifuge, it's extracted inside a sterile container, and so the entire processing is done in a sterile environment that's never reaches the external world. MSite concentrates can get up to 8 times baseline. So you can think of the advantage of that. If someone has a blood cell count that's 125,000, you're getting up to the level that the studies have shown that that's what you want. Okay, a lot of them don't get that high. All right, again, that's because it is a dual centrifuge procedure. So it takes a little bit longer. The cell fill is really quick. I mean, one centrifuge, very quick. It takes about 7 minutes, but you definitely get higher platelet concentrations with this other one as well. So, again,
Is MSite PRFM or no?
it's PRP. It's PRP. But then you start making the jump, well, when you're injecting it, and you get more of it. So you can do, say, full facial volume restoration, but you're also sort of saying you're getting a higher platelet count, and the platelets are going to be activated once you inject it. So you kind of make the leap that it's just as good.
Don't they have something that you could put in it, I think, to make it into a PRFM?
You can add calcium. You can always add calcium and activate it yourself. And some people will do that. They'll just take a cc of they'll just get calcium carbonate from which is cheap, and they'll just add a cc of that.
What is it, calcium carbonate? Is there a percent to that, or?
Yes, and I'm trying to remember what that is right now. I'd have to get back to you and look that up and see what it is. So, as I said, the MSite is completely enclosed. Essentially, it's sodium citrate is already in an initial drawing tube, so the blood does not clot, and that's in red top tubes as well. The sodium citrate. Blood is withdrawn, and then it's centrifuged at 3,800 RPMs. And at that point, the plasma suspension and the buffy coat, the red blood cells, are just taken off, and then it's centrifuged again, so you just get this platelet concentrate, and then that is just resuspended. And it's pretty simple, but that's how the system works. The system makes it so it's really simple. You can see that if you can obviously create your own, but their specific kit system, it's designed to really easily remove the red blood cells, so it takes away contamination of red blood cells, which you don't want. Hair restoration protocol, they have one specifically for hair because it has an appropriate amount of leukocytes that it's supposed to reduce burning in the scalp, because sometimes PRP, when you inject it back in, it does burn a little bit. And so they call this the no burn protocol. I haven't had this one injected, so I can't necessarily personally attest to that, but I will say that patients that I've injected, there's some burning from just injecting anything, and it does seem to be that it's less with theirs. So one thing you can do with them, because you're harvesting a platelet pellet, if you then resuspend it with a little bit of plasma and you were to check the platelet concentration and it's too high, you can then tinker with it. I mean, so it's nice if you use some of the kits, you don't know what's in there that you're injecting back into them, so you can't really tinker with the concentration. You just get one concentration, and that's it. So their kit, because you're getting a platelet pellet, you could actually theoretically, you could change it per patient if you wanted to market it that way. In practicality, I mean, you sort of asked that. In practicality, from what I do and colleagues, we just do it and inject it into the scalp, and don't always check, the platelet concentration that you get. Another company, there are companies that make various procedure packs to do all this. This company actually they make little injection guns, so when you harvest it, you can just set it at a tenth of a cc and just go and it will just punch it in. However, using just like an insulin syringe, it's actually pretty quick as well. So it just depends on what you want and what you try. And they make various packs to get certain amounts. If you find that you're using 20 cc's every time, they'll make packs to get 20 cc's. This is just another company. I'm just going through this, but they all market that the the platelet concentration that they get is of varying amounts and stays that amount. Insight does seem to be some of the highest that you get. So again, having about 5 times normal puts you in about the range that the studies have shown that it's most effective. Again, that's putting it in the range of about 1.2 to 1.5 million platelets. And then this goes into the question, I was just saying this again, PRP activation. Do you want to do it? Do you not? People will argue that if you do it, it's causing those platelets to slowly release what's in the alpha granules over time, and it's trapping things. But if you activate it too early, you lose some of your material and you run out of time. It's reasonable to get one of those kits and try it and see what you prefer. But you don't want premature activation of platelets. This just goes in to show what traditionally is PRFM, which is actually just without even centrifuging the blood. This is what orthopedic surgeons do. Or they centrifuge it one time, and then they allow the plasma and the buffy coat, they just mix it up and allow it to clot. And that's initially what they would just put in as platelet-rich fibrin matrix, is actually just the clotted plasma. Those are some companies that offer that, Fibrinet and Cellfill. Cellfill is the one you see for cosmetics most often. Fibrinet is the one you see for orthopedic surgeons.